Hello and welcome to today's tutorial as part of the On-Call Survival series. Today we're joined by Miss Riana Patel, who is an ST3 registrar in Orthopaedic Surgery based in East London at Queen's Hospital. Over to you.
Brilliant. Thank you so much for organising and thanks for having me today. So today we'll be going over orthopaedic emergencies. Hopefully by the end of today, this will help improve your confidence at managing orthopaedic emergencies at a foundation doctor level. And I know that often when you're a foundation doctor, you can be a bit worried to call the orthopaedic reg on call. But we are a friendly bunch and hopefully you'll get to know that by the end of this. But this will give you an idea of the basic things you can start doing before escalating to your seniors. And hopefully this will give you a breakdown of both the history, examination, and the investigations you need to know, as well as a bit of background on some of these key emergency topics. So I want to do this as a case-based discussion. I know we've got a few of you here today. Has anyone got their microphones on and willing to sort of take part?
Yep, they're on.
That's quite all right if not, but feel free to shout out throughout if you want to answer any of the questions, or try and type it into the Zoom meeting on the side. So we're going to start off with this case here. And so you'll imagine that you are the night FY1 doctor and you have been called to see this patient on the ward due to the right calf pain. So this patient is a 42-year-old male builder. They came in the day before with a right tibia and fibula fracture, and they've had what we call an intramedullary nail fixation this morning. So what we're looking at here is an X-ray. So it's an AP or anterior posterior view. Sorry, I'll go back there. X-ray. This right here is the tibia or the shin bone and the fibula. We can see there's a fracture line here. You can see those lines. There's also a fracture line in the fibula here as well. So they've had quite a significant injury. What we're seeing here, this rod and pins, is that intramedullary nail operation that they've had. They're otherwise fit and well, but you've been called to see them. Prior to going to see them, you've got to have a think about, what are you thinking about? Is this a patient I should be worried about? Is this a patient I shouldn't be worried about? And we often talk about our surgical sieve, which means we break down what are our differential diagnoses into different things. So is it vascular? Is it infective? Etc. So before we're going to see this patient, we have a think on the walk up there. And you think about some differentials. And does anyone want to sort of shout out some of the differential diagnoses they might have for why this patient's in pain?
You want to exclude compartment syndrome?
Yeah, so compartment syndrome should be absolutely the first thing that's popping up as this is your emergency. And obviously, with the benefit of this being the orthopedic emergencies talk, you can probably imagine where this is going. But also, compartment syndrome is although an emergency, a rare cause, there is often other things we need to be thinking about as well. Does anyone have anything else they want to list? We've got some headings here. So vascular, traumatic, or infection. Anything anyone wants to list? All right, I'll go ahead and reveal the answers then. So, oh, sorry, go ahead.
Potentially infection where there's the implant.
Yeah, absolutely. And it's very early, so it's only one day after, but if anyone who's had a previous operation, you can think of it in the back of your mind. So it wouldn't necessarily be the most likely, but certainly an option. Now, in terms of your vascular ones, so calf pain, you could be thinking about DVT or an arterial injury, either from the operation or the fact that this patient has had a trauma. It can be traumatic, and this can be just simply the fact that they've got pain after the operation and they haven't been given adequate analgesia. So it may be from the trauma or the operation. And the important thing is separating that physiological pain that you'd expect after the operation from the pain of something more severe like a compartment syndrome. And we'll go through how to do that shortly. And then finally, infection. So it can be a deeper infection or a cellulitic infection from the fact that they may have had some soft tissue injury or soft tissue abrasions. But the post-operative course of this tends to be something we see after about 5 days to 7 days. So it's still quite early for that. So that's once again going to be lower down on your differential list. So in terms of your approach, we always want to take a bit of a triple assessment, and this includes history, examination, and investigations. And if you remember anything from compartment syndrome, I've put the word here in big, pain, and people will say the 5 Ps, and those 5 Ps should be pain, 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 and pain for compartment syndrome. So particularly this one, they always talk about pain out of proportion to what's expected. And obviously this comes with experience, you can see what to expect. It also depends on sort of the other factors such as the injury level, the mechanism and timing of injury, whether the patient's been given any analgesia. So if they've not been given any analgesia and they're in significant pain versus they've been given 50 milligrams of morphine and there's in significant pain, you can imagine that that second patient is going to be much more worrying to you. So these are some of the questions that you want to ask in your history taking. And I know you guys are all familiar with that Socrates pattern, but just want to make sure you're asking these key questions about how they had painkillers. Rating their pain using objective scales on a 1 to 10 method is really helpful to track it over time because it's very personal and allows the patient to subjectively rate their pain, and certainly pain out of proportion to what's expected. In terms of the examination, for an examination in any orthopedic examination, you always want to go through your look, feel, move approach. And when you're going to go by that patient's bedside and you're going to have a good look, the first thing you want to do before you even get to the patient's bedside, you're even standing outside their bay and you can listen to what they're hearing. So a patient with compartment syndrome may be howling before you even get there. And I remember on a night shift, I had to call the consultant, and there's a patient we were worried about compartment syndrome, not too dissimilar from this case. And the first thing he did is went, stop and listen. And you can hear the patient screaming from the corridor. So these patients will be extremely distressed because they're in huge amounts of pain. You can look for the presence of circumferential dressings, things like plaster casts or bandaging. And then finally, you can look for the presence of skin swelling or any skin changes. When you go to feel, you can feel for the presence of any soft or tense compartments in the lower legs. The one thing about this is actually what we know from studies is that there's poor sort of reliability of our clinical examination when it comes to feeling whether a compartment's soft or tense. So just keep that in mind and always have a high threshold for suspicion in certain patients. The compartments might be tender. And importantly, what they always talk about is pain on passive stretch of the compartments. Finally, as with any examination of the limb, you always want to think about examining the neurovascular status of the limb. And then finally, I put move. Now, these patients may be very hesitant to move, and you certainly want to include that as part of your examination. The reason I put that there is you certainly want to get a move on, because if you're suspecting compartment syndrome, it is certainly a limb-threatening orthopedic emergency, and you want to start thinking about things you can do and thinking about who you need to speak to. I just wanted to highlight specifically about neurovascular status, because often what you might see as medical students is people have documented in the notes DNVI, and people love shorthand for things. Now, DNVI is short for distally neurovascularly intact, but actually, if I were you, I would really try and avoid this shorthand. Firstly, it really is not very specific in terms of what your examination findings are, and you guys are all doing very specific examinations. Secondly, medico-legally, it doesn't stand up, and we've been advised not to use these sort of abbreviations. So if we think about neurovascularity, I'm going to talk specifically about the lower limb because that tends to be where most people think about with compartment syndrome. So from the knee down, so that calf area. And so the vascular status, the things that you should be thinking about, both looking and documenting. So you want to examine the capillary refill time. So squeezing the finger or toe for 5 seconds and looking and counting the number of seconds for that color to reperfuse. Thinking about the color, the temperature of the limb. Is it warm? Is it pink? Is it well perfused? And then the distal pulses. So particularly in the foot, you're going to get your dorsalis pedis and your posterior tibial pulses that you can feel for. The posterior tibial pulse will be posterior to the medial malleolus. And the dorsalis pedis will be on the dorsum of the foot between the first and second metatarsals. And finally, the neurological status. So the nerves you want to test for, those distal branches of the sciatic nerve. You've got your deep and superficial peroneal nerve and the tibial nerve. In terms of examinations for this, I would advise just having a quick look at a textbook before re-examining or making a note of it so you can remember this in person. But if you're examining the sensation for the superficial peroneal nerve, it's in that first web space between the first and second toe. The deep peroneal nerve you can assess on the dorsum of the foot with the exception of that first and second web space, and the tibial nerve feeling for sensation on the bottom of the foot. Now, I want a quick quiz for you guys, just to check you're awake and still with me. Now, when we're talking about the lower leg, how many compartments do we actually have in the lower leg? Does anyone want to sort of have a guess here? Is it 1, 2, 3, 4, or 5?
4 if you consider anterior and posterior as 2 separate compartments.
Absolutely. So you're absolutely right. It is 4. And I've got a picture of the compartments here. So we've got 4 compartments. So we've got your anterior compartment, which is certainly a separate compartment. We've got your lateral compartment on the outer aspect. And we've got 2 posterior compartments here. So we've got your superficial and your deep. And you may be wondering, this is very specific anatomy knowledge. Why is this important? The reason for this is because when you're examining, we always talk about pain on passive stretch. And what you need to be doing is you need to be stretching all of these compartments to see if it's exacerbating the pain. So if you're only plantar flexing the foot, you're not actually assessing the rest of the compartments. So if you think about it, when we get this lateral compartment on the outer aspect of the foot, the lateral compartment normally is responsible for active eversion of the foot, or moving the sole of the foot away from the body. So to stretch that, you want to invert the foot passively, see if that worsens the pain. For the anterior compartment of the foot, it's responsible for dorsiflexion. So you want to plantar flex the foot to stretch that out. And finally, for the posterior compartment where those, gastrocnemius and those calf muscles are, you want to then dorsiflex the foot to put stretch on that compartment. So just make sure when you're examining for pain on passive stretch, you're actively stretching all 4 of the compartments of the lower leg. Now, we've gone through the history, the examination, and while you're at the bedside, you want to look at the chart. So this is a common OSCE question. They'll ask, what things do you want to ask for? And in this, certainly you want to ask for your bedside observations, so you can see the patient's observations. You want to have a look at the operation note and see what the patient's had, whether there are any intraoperative complications. You can look at the anesthetic chart, and specifically what you're looking at is, have they had a regional anesthesia? So have they had a nerve block in the area? And often that may mask the presence of a compartment syndrome. So if you've got tense compartments in an otherwise comfortable patient, it may be you want to check that, have they had a regional block? Because your suspicion would be much higher if they had, that this may in fact be a compartment syndrome. And finally, you can check their drug chart. So like I said earlier, you can see how much pain medication have they had. If they're in a lot of pain despite a lot of pain medication, you should be very worried that this is an acute compartment syndrome. Now, the question is, what is compartment syndrome? And I know it's a term that's bandied around quite a lot. And I just want to quickly go over exactly what we mean by that. Now, we talked about these 4 compartments of the lower leg. And those are compartments of muscles, nerves, blood vessels, all contained within a fascia, which is a tight sheet almost. So you can imagine it's almost like a bit of a balloon. And effectively that pressure will expand and make all those structures nice and tight within that. And often the causes of that may be from a fracture, it may be from a surgery, but in any case, you get swelling within the compartment. And that swelling will stop the venous blood from leaving the compartment. And then because the venous blood isn't leaving and you get the venous stasis, the arterial blood's therefore not coming into the compartment. And that decrease in tissue blood flow leads to tissue hypoxia, tissue ischemia, and worsens that edema. So it becomes a bit of a cyclical cycle that continues to worsen itself. But the important thing is, the reason this is limb-threatening is because we're getting ischemia of the tissues within that fascial compartment. Now, compartment syndrome can be caused by a number of things. And the reason this is important, because these are the risk factors for patients you should be thinking, is this a compartment syndrome? And the obvious ones that we mentioned from this case that you hopefully remember is firstly fractures. And so the fracture, whether it's open or closed, can still cause compartment syndrome. So just because it's open, it still needs to be in the back of your mind. It can be in the context of significant soft tissue trauma. So a patient who sustained a crush injury, for example, or been run over by a vehicle. It can be iatrogenic, so it can be caused by us putting on casts that are too tight or bandaging that's too tight. It can be caused by bleeding, or if you get any extravasation of fluid. So that can be an intravenous injection that we've given, also in the context of intravenous drug use. It can be a reperfusion injury, which means after a patient has had prolonged ischemia, such as from an arterial injury, they're at high risk of developing compartment syndrome. And finally, in burns that are circumferential, what you get is that tissue thickens and almost can cause a constrictive effect. So you can get a compartment syndrome in a burn that is around an entire limb. So these are patients where you need to start thinking, could this be compartment syndrome? Now, how would you manage it? Now, an acronym I've got here is DANCER, and you may be thinking, what does dancing have to do with orthopedics? But these are the sort of key 6 things that you need to do if you were to see a patient with compartment syndrome. The first thing is documenting your findings, so including time and date. You want to make sure you've got a patient in front of you who's uncomfortable, so you want to give them analgesia. This is really important because you can reevaluate and see if they respond to analgesia. That's one of the factors that can help you differentiate between, is this a normal pain from an operation, or is it the pain of compartment syndrome, as this is something that you're going to be frequently called about as a foundation doctor if you're doing any sort of surgical or orthopedic job. I would suggest in any orthopedic emergency and any surgical emergency, if there's even a possibility the patient might go to theatre, it's important to make them nil by mouth, because you're better off keeping a patient nil by mouth for an extra 30 minutes rather than feeding them and potentially delaying a life or limb-threatening operation. So you want to make sure you tell them, as well as the nursing staff, this patient should be clearly nil by mouth. The C is for circumferential dressings. Now, this can maybe a cast, it may be a bandage or whatever, but you need to see skin. So you need to cut that cast. And often what you find is people may cut the plaster, may not cut the wool underneath it, but you should be seeing skin when you cut any sort of circumferential bandaging and to help release any pressure on the area. The E stands for elevating the limb to heart level, but also escalating to your senior. So if you think there's a patient with compartment syndrome after evaluating, you want to keep them nil by mouth and call your senior colleague, whether that's your registrar, or if you're a consultant or a registrar yourself, calling your consultant, which is something that we all need to do. And then finally, specifically with compartment syndrome, it can be difficult to differentiate. If it's a barn door case of compartment syndrome, then obviously you need to escalate and think about getting that patient to theatre within an hour of the decision to operate. If there's any uncertainties, you want to give them analgesia and reevaluate them within 30 minutes to try and see if there's a response to that. Because if their pain completely resolves, that may sway your idea away from that this may be compartment syndrome. The important thing in compartment syndrome, though, the reason that I've stressed this one so much, and I know that obviously it's something that comes up frequently, is often it is a very clinical diagnosis. It can be very difficult to differentiate, though, between compartment syndrome and what is normal physiological pain, which is why actually experiencing on the wards and seeing this on your foundation jobs and as a medical student is just really essential. It can be specifically difficult, however, if you've got a patient who's unconscious, or if you've got a patient that's borderline, so you've given them pain relief and they've had some response, but their pain is still out of proportion to what's expected. Now, does anyone know what you can do if that's the case? So if they're an unconscious patient in ITU with polytrauma and you're suspecting compartment syndrome, what are your options? I've got a nice picture here, so hopefully it makes it a little bit easier if anyone's seen one of these before. There's a key in that it's written on the arrow. Does anyone want to give us a guess?
Measure the pressure?
Yeah, absolutely. Now, routinely, this is not something we do. And the reason that it's a clinical diagnosis is the important thing in compartment syndrome is we're really looking at tissue ischemia. And pressure may be a surrogate marker, but it doesn't necessarily indicate whether there's ischemia or the level of ischemia. There can also be technical difficulties in actually getting accurate pressures. But in the unconscious patient, it can be a really valuable tool to help with your clinical diagnostics. And what you do is you get this needle with a syringe and a pressure monitor, and then you insert these in the compartments. And once again, much with the pain on passive stretch, you need to be inserting it in all the compartments to measure them individually. So in this case, in the lower leg, as I mentioned earlier, the anterior, lateral, deep and superficial posterior compartments, and measure the compartment pressure. The cutoff pressures, if you remember anything from this lecture of compartment syndrome, I want it to be two things. One is that pain is the most important thing, and two is the pressure of 40 millimeters of mercury. So pressure of above 40 millimeters of mercury is when we're going to be thinking compartment syndrome. Or the alternative is looking at the difference between the patient's diastolic blood pressure and the pressure measured on the monitor. And if that's less than 30, then you should be thinking about compartment syndrome. But escalate, escalate, escalate. Does anyone have any questions about compartment syndrome at all? No. All right. Well, if you have any questions towards the end, please go ahead and bring them up later. But we'll move on to our second case now. So this is something you'll also be called about quite frequently if you ever do an orthopedic on-call. So we've got a 65-year-old male with a 10-day history of a swollen right knee. He's got a background of chronic kidney disease. Now, you are the FY1 in orthopedics, and you've been asked to come and evaluate this patient as to whether this could be a septic arthritis. They've given you observations, and these are all within normal limits. So they've got a heart rate of 75, a normal blood pressure of 135 systolic, and a temperature of 37 degrees. You've got their bloods back, and we've got their normal ranges. So you've got a normal white cell count, a normal CRP of less than 5, and a normal ESR. So we've got normal bloods and normal inflammatory markers. Finally, you go and examine this patient, and the range of motion in the knee is from 0 to 120 degrees. 100 degrees, and they're able to walk on the knee. So you can see them walk into the examination room, although a bit of discomfort on walking. Now, you've been asked, do you think this is septic arthritis? And now I will hopefully put this out to the audience because it's a yes or no, so it's 50-50. Do we think this is septic arthritis?
Technically, yes, until proven otherwise, but it could be gout.
Okay, I like the answer. I like the answer. Now, obviously, you always want to keep it in the back of your mind. This is an orthopedic emergency, but more often than not, once again, these are rare conditions. And the important thing is being able to differentiate between what is a septic arthritis and what is not a septic arthritis. And if it's not a septic arthritis, what we're looking at. Now, the things here that might point you towards a diagnosis one way or another that I will point you to is, firstly, it's a 10-day history. So in a patient who's got pus in their knee after 10 days, we expect them to have some sort of inflammatory response or some sort of systemic response. So we can see here they've got a normal temperature, normal bloods, and normal inflammatory markers. So after 10 days, that's pointing you a little bit further away. Chronic kidney disease, the reason I've highlighted that is that's a risk factor for developing gout, which can be another common differential diagnosis. Finally, looking at their range of motion. So a patient with pus inside of a joint is going to have very limited range of motion. And that's a combination of pain and the fact that they've got that distension of the joint. So from 0 to 100 degrees is very, very good. And they're able to walk comfortably on it. And these are all risk factors. And now by themselves, not one single one can say this is septic arthritis, this is not. But generally having a look at this picture, you'd be less suspicious because this is a long-standing history in a patient who's systemically well and is moving their joint comfortably. So you're thinking that this may not be a septic arthritis. And if it's not a septic arthritis, however, what's our differential diagnosis? So we want to go back to that surgical sieve once again. Does anyone have any differentials that they can think of that might be? All right. We'll go ahead and list a few here. So we always think about infection. So in children, a really common differential diagnosis is a transient synovitis. We've had a recent, commonly a viral upper respiratory tract infection, and they get inflammation of the synovium, which can cause irritability, often in the hip joint. Osteomyelitis, or infection in the bone. Cellulitis, or an infection in the overlying soft tissue. A bursitis, or an inflammation of the bursa which are these sort of fluid-containing pockets around the joint that help cushion the joint. Autoimmune causes, so our crystal arthropathy, and that may include gout or pseudo-gout. Inflammatory arthropathy, such as rheumatoid arthritis. It can be trauma, so are we actually missing a fracture? Bleeding, such as hemarthrosis into the joint, such as in a patient with an underlying cause, such as anticoagulant or hemophilia. And they can often be iatrogenic, so if the patient has a post-operative, such as an arthroscopy, where we're putting a lot of fluid in the joint from our keyhole operation, then knee might be swollen. Now, when you're breaking it down, as we did before, into history, examination, and investigations, in your history, you want to be asking about several things. So you can ask about the duration. So is this an acute onset or a chronic onset of their symptoms? Do they have any systemic features of being unwell, so any fevers, etc.? And particularly in children, as I mentioned earlier, we can talk about have they had a recent upper respiratory tract infection, which may be a cause of something like a transient synovitis, as I mentioned. Examination, once again, we want to go back to our look, feel, move structure with all orthopedic examinations. So you can look at the end of the bed. Does this patient look well or unwell? And just because they look well doesn't necessarily exclude a septic arthritis, because they may not necessarily have that systemic inflammatory response just yet. You can feel the joint. You might be looking for redness, warmth, tenderness along the joint sign, the presence of an effusion. And you want to ask them to move them. So you might find that they've got this limited range of motion and inability to weight bear, particularly on the lower limb joints, such as the knee. Now, following this, you may need to do some investigations to diagnose it completely, because obviously we can't completely rule it out just on a clinical examination or just from the details I gave you earlier. So you, as the FY1, decide to take initiative and do some investigations. Now, the first thing you can look at is your bedside observations. Once again, they're very useful. Does the patient have a temperature? Are they tachycardic? Are they hypertensive? You want to look at their blood. So on your full blood count, you're looking for, do they have a raised white cell count? Their Usenis. You're looking at inflammatory markers, so your ESR and CRP. On your VBG, you always want to get a lactate to see if the patient is well or unwell. And you can think about adding a urate on if we're thinking about differential diagnoses such as gout. We want to think about getting blood cultures, particularly if the patient's spiking in temperature. We always want to get an X-ray, looking at other features. So could this be a fracture, or could there be anything else going on? MRI and ultrasound are limited in septic arthritis and are more useful if there's any doubt to what the diagnosis may be. Diagnostic to figure out could this be a septic on? And I've got two pictures here. So this is a nice clear yellow synovial fluid. Sorry, I do apologize about that. I think my Wi-Fi just cut out there. Can anyone see my screen still?
Yes, all good. Thank you.
Lovely. Sorry about that. And you want to, over here on the right-hand side, we can see that it's more turbid fluid, and that's why we'd be more suspicious of an inflammatory. This is pus here, so uh, uh, we'd be more suspicious of something like a septic arthritis. Now, there's Cocker's criteria, and this is very useful in helping to diagnose it. And in terms of this, it was originally designed to help differentiate a transient synovitis between a septic joint in children. And there's 4 criteria here, so non-weight bearing on the affected side, an ESR of more than 40 or CRP more than 20, a fever of more than 38.5, and a white cell of more than 4. And actually, what you can find is, depending on the number of these criteria the patient fulfills, it increases their likelihood of septic arthritis. So, if a patient's got 4 out of 4, you've got a high chance of septic arthritis. And although the initial paper was not initially looking at other joints, it can be a useful marker to kind of give in your mind, is this a septic arthritis or not? In terms of a joint aspirate, this is something worth looking at online and watching some YouTube videos, but something that you will probably need to have some training before you would go ahead and do it. So while you're on your rotations, I would really recommend, if anyone's going to be doing a joint aspirate, it's worth following and shadowing to try and see how they do it and get an idea of how this is done. There are certain contraindications, however. So if you've got overlying cellulitis or skin infection, you don't want to introduce deeper infection. They've got a fracture, you don't want to put a needle in because you create an open fracture. They've got metalwork, such as a knee replacement, you don't want to put a needle in there. If they've got any bleeding disorders, anticoagulation or coagulopathy, it's it's not a contraindication, but you need to be aware that there's a higher risk of bleeding and counsel the patient on that. And finally, you want to manage this patient, and escalating to your senior is really important if you're suspicious of septic arthritis. And it depends on whether the patient's well or unwell. And this is where it differentiates generally from most other things where we put sepsis in. Because normally we talk about the sepsis 6, where you want to give antibiotics immediately. However, in the context of a well patient, actually the important thing is you really want to hold off on antibiotics until you take samples of what bug is growing, because that will help direct your antibiotic therapy, as these patients often will need prolonged courses of antibiotics after their initial washout. In this case, you want to think about keeping the patient near by mouth, consenting and marking them, and then going for a washout in theatre to really wash the pus out of the joint. And that can be done either keyhole arthroscopically or as an open operation, which is less common these days. On the other hand, if the patient is unwell, however, do not delay giving antibiotics as a priority, because in this case, it's a life-saving thing. And you want to go for your sepsis 6, and then getting the patient near by mouth, consenting and marking, and ensuring that they go urgently for a washout in theatre. And the question is, why is this an emergency? Now, obviously, we've got pus in the joint, we've got a lot of inflammatory cytokines, and this can lead to the breakdown of the articular cartilage, leading to long-term joint destruction and deformity. In children, it can cause growth arrest, and it can also cause the spread of infection to the nearby bone or systemically causing sepsis. So this is why this is a really important condition to know about, and hopefully that's giving you an overview of how to manage it. We'll finally finish off with our last case, which is going to be an open fracture. So you're called to A&E to review this 32-year-old lady who sustained an ankle injury following a horseback ride. She's otherwise fit and well, so you walk into A&E and you see this is her ankle that we're looking at here. Now, does anyone want to say what they see? Particularly looking at this little area here.
The
What we're
tibia,
seeing there is, what, sorry?
tibia sticking out?
Absolutely, yeah. So we're seeing bone. And now we shouldn't really be seeing bone at the bedside. We should be seeing this in the context of an x-ray. So this is indeed an open fracture. And you think, what should you be doing? Now, in terms of your approach, with surgery like structure, so we talk about our surgical sieve, we also talk about how we approach things in terms of our immediate management, our early management, and our definitive management, or how we're going to treat this. As your immediate management, the first thing you should do for this sort of patient is anytime there's an open fracture, what we know is this is a high mechanism of injury. So the patient may have other sort of injuries. And I know orthopedics has the reputation of there is a bone, I must fix it. But actually the one thing we're taught in our ATLS or our trauma call trauma call setting is that these patients may have other life or limb threatening injuries. So it's important that we put out a 22222 call and ask for a trauma call to be put out. And that means all members of the trauma team will assemble. And that includes our anaesthetists, our general surgeons, our orthopedic surgeons, as well as our A&E staff to make sure we're assessing this patient in a full A to E manner to systematically identify and treat any life-threatening injuries before we move to things like our limb-threatening injuries. Now, in this patient, once you've excluded any other life-threatening injuries, we can go ahead and manage the open fracture. And in this case, you want to do several things in terms of your early management. Now, if there's any obvious bleeding, you want to try and control this by using some direct pressure, so just putting some pressure on it. Or you could, in worst case scenario, if you can't control it using pressure, you can consider the use of a tourniquet. You want to examine their distal neurovascular status, as we've described before, and examine for the presence of compartment syndrome, because this would be an emergency. And as we've mentioned earlier, you can still get compartment syndrome in the context of an open fracture. Now, the old thinking used to be you go into A&E, it's super exciting, you're going to wash it out there and then with bags and bags of saline. And actually, what you may be doing is washing that dirt further into the wound. So nowadays, the thinking is any gross contaminants or large pieces you can remove from the wound with forceps, you should. But other than that, you just want to cover the wound with some saline-soaked gauze and an occlusive dressing. At the time of injury, it's important, if you can, to get official medical photography of these injuries. And the reason for that being is because if you don't take a photograph, every time someone wants to see the wound, they're going to be lifting it up and they're going to be having a look at it. And that obviously increases your risk of infection. The real thing we worry about with these sort of open fractures, they are limb-threatening injuries. It's at risk of underlying infection. So you want to give antibiotics as soon as possible with these patients according to your hospital guidelines, as well as a tetanus booster if they need one. And then finally, as this is an open injury, we can see that the bones are obviously out of proportion. So we want to ensure that we splinter this and we're going to put an appropriate plaster on. And often this may require the help of the orthopedic team, so one of your seniors, or the A&E team if they're happy to help, and placing this plaster and getting some x-rays to see what we're managing. Now, in terms of your early management, things that you may be asked to do yourself, or you may be helping to do when you're a foundation doctor, firstly is your ample, so taking your history from your patient, so your history, your examination, as we've mentioned. You may be asked to take bloods from this patient, so thinking about if this patient is going to need to go to theatre, so thinking about taking a full blood count, coagulation, U&Es, and clotting screen if they need one, as well as a VBG for lactate. With the help of your senior, you can consent and mark the patient for theatre. You want to think about keeping them nil by mouth from the appropriate time and giving IV fluids. And you want to escalate this to your registrar, your on-call consultant, and particularly when the patient is going to theatre, you want to ensure that you've spoken to the anaesthetist and theatre coordinator. So often this requires a huge team effort, and you'll be one part of this massive sort of working wheel. In terms of your definitive management, there's really three aspects we need to look at. One is the prevention of infection with these open fractures, which is a really important thing. Secondly, it's a soft tissue injury. So for a bone to exit through the skin, the amount of force that's gone through, it's actually a soft tissue injury with a broken bone rather than a broken bone with a soft tissue injury. And finally, being orthopedic surgeons, we always want to think about the fracture. So we're managing a fracture at the end of the day, so stabilizing that for the patient. With regards to the risk of infection, this really dictates how soon this patient needs to go to theatre, so how quickly you need to call your consultant in. If it's highly contaminated, and what we mean by highly contaminated, if it's your really dirty environment, so particularly farmyard environments, aquatic environments, or sewage, you get a lot of bacteria in there. So this is a patient you may need to go for an immediate going to theatre. Additionally, if there's any vascular compromise, whether that's compartment syndrome, or in the presence of an arterial injury. If it's a high energy injury, you want to think about 12 hours. And if it's a low injury, they need to go to theatre within 24 hours to help reduce that risk of infection. And in theatre, what we'll be doing is giving a good wash, debriding any tissue that may be dead, as this may be a nidus spore infection. Once we've debrided, what we can do is we can classify this according to the Gustillo-Anderson classification. And this really just, the purpose of this is that it's largely prognostic. And the one thing to remember is that the Gustillo-Anderson classification is only after you've debrided or taken away all of that soft tissue that's dead or devitalized. And this gives you an idea of obviously in orthopedics, we love 1, 2, and 3. And 1 is, it's kind of bad. 2 is even more bad. And 3 is always going to be worse. So if you ever know any orthopedic classification, generally 3 is worse than 1. So in this case, what it means is the higher the classification, the significance of that is that it leads to a higher prognosis of infection. So if you've got a Gustillo-Anderson 3, meaning you've got an extensive wound, an extensive open sort of soft tissue injury, after you've debrided it, your risk of infection is going to be much, much higher. Next, we talk about soft tissue injury. Now, with an open fracture, it's really important we work closely as orthopedic surgeons with our plastic surgeon colleagues to think about the soft tissue injury and how we can repair that. because there's no point repairing a bone and then leaving it open with this wound, because it's going to get infected. That whatever you put in there metalwork-wise will get infected. And there are plenty of options, but it's at the time of operation, it needs to be a really coordinated effort between our plastic surgeons and our orthopedic surgeons working hand by hand in terms of debriding out the infected tissue, closing the wound, and making sure that we've got the appropriate fracture stabilization. And that can mean that they either stitch together in the first operation. They can think about things like local or distant flaps, or negative pressure dressings, which involve vacuums and sponges that are placed over the wound area if it's not able to be closed as coverage. Finally, we can think about stabilizing the fracture. This is the orthopedic side. And so the method of stabilization may be an external fixator or an internal fixator, but these are decisions that need to be made by both a consultant orthopedic and plastic surgeon at the time of the operation. And hopefully that gives you a bit of an overview of both the immediate management, what you might be doing, what might be happening later down the line for the patient journey, so you can help explain this to the patient as you see them in A&E. But does anyone have any questions about this case at all?
No questions.
All right. Well, if you have any questions that you think of and don't feel like you want to say it out loud, because obviously it can be quite daunting in a meeting with lots of people, please feel free to reach out. I'd be more than happy to answer any questions after this. But thank you so much for having me today, and thank you, Tiffany and Surgical Academy, for organising.
Thank you.